Our next topic is vasculitis, right? A large and a very important topic. I want to get this done so we are very primed for any sort of nephrotic discussion. And we're also done with a part of like a important part of rheumatology, right? Vasculitis in its general understanding is just inflammation of blood vessels, large, medium, small. That's the distinction that we're going to follow, right? And as you go down, let's review a little bit of histology to help us understand. There is three layers: intima, media, adventitia, right? Both of these have elastic laminas in between them, right? So the intima is the innermost endothelial cell. It's the thing that makes the lining smooth and contained. A chemostaxis can occur through these endothelial cells, transidative, exudative, effusion, all that, right? Um, the middle elastic lamina is called internal elastic lamina. Then you get the muscular layer, right? In arterioles, you have smooth muscle cells which can contract and control your BP and etc. And that control is over here, right? Then comes the external elastic lamina, and then comes the tunica adventitia. This is a tough outer layer. It's like the serosal layer, and you can see and appreciate those layers in this stain right here, where it highlights the fibrin, accumulation, and this are the two elastic laminas, right? The stain that is usually used is called the Van Giesen stain. Usually not asked, usually a step one sort of question, but just mentioned in there. Now, within the endothelial cells, right? Within the endothelium, you have something called Weibel-Palade bodies, right? Now, you will see these being mentioned and asked in terms of clotting because they consist of, one Willebrand factor, when it comes to chemostaxis, P-selectins, a couple of markers that you will see when it comes to endothelial cells and Weibel-Palade bodies are the CD34 and 31, right? We need to remember this because tomorrow, if there is any sort of, endothelial cell cancer, cell tumor invasion, or there's leukocyte adhesion deficiencies, the conversation starts here, right? A couple of more familiar factors, VWF versus factor A, are also present in this Weibel-Palade and helps. Lymphatic channels also have a marker, and this is called D240, and usually not asked, but it's just mentioned here. Then comes the distinction or a classification of vasculitis, right? It's called the Chapel Hill classification: large, medium, small, right? Usually large, the two T's, okay? The two T's are the large ones. The medium vessels are PKB, right? And the small vessels, usually you divide them into pauci-immune versus immune complexes, right? And if you know about hypersensitivity and how these work, we're going to look at how most of these vasculitis occurs. But just to mention it, immune complexing means hypersensitivity type 3, and pauci-immune usually means hypersensitivity type 2. Okay. Now, the only outlier in terms of all of these diagnoses is Behçet's disease, and that accompanies all these different types of vessels: large, medium, small, throughout. Okay. So those are all the diagnoses that we're going to learn, right? And let's start getting into the large vessel vasculitis, right? Now, also called temporal arteritis, giant cell arteritis, very, very, easily understood and common presentation, okay? Giant cells, and what you end up seeing in these, biopsies are granulomas, right? So what they say is segmental, granuloma formation. Where does the granuloma take place? It takes place in the superficial temporal artery, okay? Usually presents with throbbing headache, usually unilateral. Most specific symptom is jaw claudication, so painful, right? Painful jaw movements, maybe even eating, chewing, everything, right? Because it can, maybe influence the ophthalmic artery, you can have unilateral loss of vision too, okay? Other things that is correlated to is something called polymyalgia rheumatica. Is basically rheumatoid arthritis without any of the joint complaints. It's just massive inflammation throughout the plasma. Okay. We'll look more into this when we go into rheumatology, but for now that's just a basic understanding. Okay. Now, because as I said, it has segmental, right? It's not continuous. So you do have to do a biopsy, but the biopsy has to be in, certain lengths, right? And sometimes the biopsy may miss those nodules altogether, right? So we have to make sure that even if the biopsy is coming negative, you have to take, first of all, you have to take multiple specimens along that path, right? And if a couple of those biopsies are negative, we were not going to conclude it out. We just know that, we have a segmental lesion along that artery, okay? Now, keep going further. Now, this is the criteria of how the American College of Rheumatology wants you to conclude the diagnosis, right? I just want you to look at where the scores are the highest, right? And how can you sort of, come along to, diagnose the person with GCA, okay? So let's just start here, laboratory imaging biopsy criteria. You see, first of all, high ESR with high CRP, right? Indicative, okay? You do a biopsy, very, very indicative, right? Or maybe you do a temporal artery ultrasound, right? Maybe axillary involvement, right? You may see that as a like an additional point, or you do, a PET scan, which basically shows you higher amounts of metabolism happening in these certain sections, and you may see that in the aorta, you may not. Okay, but out of all these, if you just get these two, you're already +8, right? And all you need, is for them to add up to greater than 6. Okay, so just with this, you already confirmed the diagnosis. But apart from all that, all these clinical signs and symptoms are just additional criteria to see, what your diagnosis is. And as I've stated before, it's usually an older adult onset disease, right? So whenever you talk about GCA, you're probably not looking at a 15, 20-year-old, right, or a young adult. You're probably looking at an older adult, okay? So always double check that as your diagnosis goes, okay? All right, so biopsy, as I said, may be repeated in more than one places. Therapeutic effects as nerve endings are cut because of the biopsy itself. Giant cells can be seen in the thing, and giant cells are just multinucleated cells formed out of macrophages under the direction of T cells, right? Under the action of T cells. Neutrophilic infiltration, throughout all the layers of blood vessels, right? So what you end up seeing is something called panarteritis, right? So you see when you look at these images now, histological images, you see the entire vessel wall has extensive inflammation, right? And then you see the lumen is completely narrowed, right? That's what they're trying to show you here as well, along with the neutrophils being present there, right? So extensive inflammation resulting in lumen narrowing, right? As well, in this, you see the elastic lamina is pretty visible here, but you see multinucleated giant cells in the images too. You see, you can easily point them out because they're this one large cell with multiple nuclei around the peripheral, right? So you can easily point out a multinucleated giant cell. Okay. Now, as far as treatment goes, the first and the foremost answer is steroids, right? Just so, I mean, we'll go over the specifics of the treatment, and I've mentioned all the different like clinical manifestation here again, but just so to make it simple for ourselves, you have to remember prednisone, right? We don't have to remember the doses, but we have to know that this is usually a high, high dose effect, right? And you have to make sure you give them enough of these, and then maybe consider a low dose aspirin, right? To make sure that they don't have any other, involvement of any other arteries, right? And they have good flow throughout these, okay? If they have vision loss, then you have to give even a higher dose to make sure that, so subside the inflammation right away, okay? The only antibody that you can come across is something that counters the IL-6 receptor, which is just the inflammatory receptor, right? Called tocilizumab, okay? Tocilizumab, right? So, silly, maybe 6, try to come up with a a name for that, all right? Or maybe 6 toes, right? Maybe that will help, okay? Tocilizumab, IL-6 receptor, right? And then you will see maybe if it's a relapse treatment, then you're using tocilizumab as the last option, okay? So we have understood giant cell temporal arteritis. We can go over the first 8 pages. And then comes Takayasu, okay? Now, a lot of students will have the predilection to go towards some sort of Asian, East Asian derived female. And if they see it in the demographic, this is the diagnosis they're going for, okay? I need our, diagnoses to be much more dependent on hard clues, right? So what are the hard clues that you're seeing in this person? First of all, the age can be a younger female, usually because, most of these autoimmune diseases are female. But in this case, unlike GCA, you have a younger male or a younger female, okay? Because it's a large vessel disease, in this case, you can see involvement of the most common involvement with the left subclavian artery, okay? And as you see here, they've done this, angiogram, and you see there's a filling defect, right? This is called the osteal narrowing, right? Ostia, which means the os, the opening of the vessel is narrowed, okay? And you see what's happening is there's this intimal thickening causing the slit-like lumen. There's no blood flow going into this anymore, okay? So now if I try to measure the pulse on the left arm, am I going to be able to, sense it? No, that's why it's called the pulseless disease, okay? One of the most commonly affected left subclavian, least commonly affected is the coronary artery, which is a good thing. We don't want the heart involved, okay? Radiologic findings, you see, filling defects, narrow vascular occlusion involves unilateral blood vessels, vascular collocation. So we've gone over most of this. You see, lower limb pulses can be normal, right? But as soon as maybe there is an involvement of some other artery, for example, renal artery, right? It can lead to renal artery stenosis. What's the most common environmental factor? It's atherosclerosis for renal artery stenosis, right? But don't just associate the two with themselves, right? Atherosclerosis is not the only thing that leads to renal artery stenosis, right? Stenosis just means a hard constricted opening, right? So it could be Takayasu having that osteal narrowing and then causing maybe unilateral or bilateral renal artery stenosis, okay? Now, another diagram to help you, most commonly involved left subclavian, and then what you end up seeing is discrepancy in blood pressure, right? Within the two arms. So right arm is going to show a different blood pressure. Left arm will probably show a lower blood pressure because of no, blood flowing through it, okay? What this presents as, if the person tries to move stuff from, the upper cabinet or move, put things on and trying to wave their hands up above their head, all those movements will cause claudication, right? And claudication causes pain. So all of this is usually termed as, vascular claudication, okay? So the problem is because, a lot of generally middle to, older adults present with, nerve entrapment, maybe other like cervical problems, it can be misclassified as neurogenic claudication, right? So how can you actually, differentiate between the two? First, vascular only happens during movement, right? When you use the arms more, when they're doing some activity, that's what's going to happen, right? Usually when you have this neurogenic claudication, if you do a CT, MRI, even an X-ray, you won't find any sort of deformities, right? No other problems are going to be seen. And then these are usually, causing pain when it's due to a disc prolapse, right? And let's say if they were given the treatment for neurogenic claudication, our patient with a Takayasu is not going to show any sort of benefits, okay? So that's when you change the diagnosis of neurogenic claudication to vascular, and then make sure you're doing other, investigations and workup to make sure you have the actual diagnosis, okay? Disparity in blood pressure, we understand that. And the radial artery with the osteal narrowing, we understand that. Okay, so usually the BP discrepancy is, at least about 20 millimeters of mercury, right? Um, you know, the difference between the legs, right? Legs is going to be constant always, but the difference between the arms and the legs is also, considered, okay? Because if it's the difference between the arms and the legs, then, if it's a usually presenting in a kid, you're going with a coarctation of aorta, right? It may be that you may see some sort of involvement in aortic dissection, right, with adults, but usually if there's a discrepancy between the arms and the legs in a young person, usually it's coarctation. Maybe in an older person, it's aortic dissection. Whereas here, we're talking about discrepancy between two arms. Okay. So conditions in which BP in the legs is greater than BP in the arm. So again, this is a very important point. Now what you're seeing is because of aortic regurgitation, you have high volume, right? And what you may start to see is that because the person is in like a dependent position, like a gravity dependent position, the legs are receiving a higher volume load, meaning the pressure measured in the legs may be higher than in the arms. So that's another very important sort of clinical sign that you may come across. Okay, conditions with unequal blood pressure between left and right arms. So there's a couple more, diagnoses, differentials that you may see. So supravalvular aortic stenosis, right? There's this genetic syndrome called Williams syndrome, right? Part of that sequelae is that you get supravalvular aortic stenosis, right? And this usually forces blood into one arm or the other, right? Usually it's the right arm, right? Goes to the right side. Whereas, similar with Takayasu, preferring, most of the blood is going to the right. Coarctation of the preductal variety, you may see that it's going towards, a different side altogether. Okay, so all these three, I do want you to keep it in mind, right? Most of these maybe, are congenital based, right? With coarctation and maybe even supravalvular aortic stenosis. You may see it in a pediatric population, but Takayasu is not a pediatric diagnosis, okay? How do you sort of work this out? We're going to use MR angiography. That's the gold standard, right? I want to visualize the blood vessels, right? Even, the complete aortic arch and even the descending aorta, because renal arteries can be involved. We know that, right? And what's the main treatment? Steroids. Okay, you have to give them steroids. So just to come back up here and figure this out, you see all these details should be very, very clear, right? And because you're seeing all these, systemic inflammatory signs, fever, night sweats, arthritis, myalgias, on top of the entire, blood flow involvement. Okay, so glucocorticoids for therapy. All right, so that was Takayasu. Okay, now we go down into medium vessel vasculitis, right? Medium vessel vasculitis, the first and the foremost is polyarteritis nodosa. Okay, polyarteritis nodosa. In this case, you see first of all, there's complete involvement of the entire blood vessel. So you say transmural involvement, but the transmural involvement, similar to what GCA did, you have segmental transmural involvement. So you may see patches of, complete involvement, but the stages of those diseases might be at different time intervals, right? So different stages of these diseases seen at same time in the same vessel, right? Some may have, early necrosis or like early inflammation, but some may have late necrosis and complete obliteration. Okay, so that's the feature of polyarteritis, right? That's why I'm saying poly, because of multiple types of inflammation. What type of inflammation? Usually, inflammation that leads to these nodes being formed on, in the vessel itself. Okay, that's why the nodosa. Okay, most common involvement. This is very important. You see, all these vessels are very, very important. Wherever they affect, that organ is going to be affected. The most common one is renal vessel. Renal vessels involvement leads to this presentation of a flea-bitten kidney. We'll see how that looks, right? But it does not affect the glomerular basement membrane or the podocyte, so we're not seeing any sort of glomerulonephritis, right? So PAN can present with a lot of renal symptoms, right? For example, hematuria, etc., right? But we're not saying that it's glomerulonephritis. Very, very important point, because the other small vessel vasculitis can present with glomerulonephritis. So it needs to be distinguished here, okay? Other vessels that are involved. CNS can lead to strokes. CVS can lead to MI. Skin, very, very high yield. Livedo radicularis. It looks like a fishnet, right? Red, brown fishnet throughout the leg of the patient or the arms of the patient. Okay, a couple of drugs can lead to that too, right? But for now, for our sake, vasculitis leads to skin involvement, leads to livedo reticularis, right? Fingers make, you may see some sort of claudication problem, some other sort of involvement. The main important point is that vessels are spared in pulmonary system. So the pulmonary artery is not involved. So the person will not show up with pulmonary symptoms in polyarthritis nodosa. That is the single most important diagnostic point. Okay. Now, viral markers. You see, most of these, not most, but some of these cases are involved with Hep B antigen. Okay, so Hep B can produce these antibodies and eventually lead to PAN. Okay. Now, this is the flea-bitten kidney, and you see the amount of punctate hemorrhaging, okay? Pinpoint hemorrhages, punctate hemorrhaging throughout the kidney, right? Now, there's a lot more of conditions, a lot more differentials of these punctate hemorrhages seen on gross, mounting, right? So what you see is, first of all, the most important one is hypertension, right? Malignant hypertension. So leading to end organ damage and organ bleeding within the cortex of the surface of the kidney. First, then we see the PAN. PAN is also mentioned here. PSGN is mentioned here, right? SLE, you see HSP and HUS also being involved here, right? Helicobacter purpura, hemolytic uremic syndrome. Wegener's granulomatosis. So just for our purposes, just to take out all the vasculitis out of it, we're going to see the granulomatosis, Wegener's, right? We're going to see HSP. We're going to see PAN, right? So these three are the vasculitis that lead to the pinpoint hemorrhaging, right? Everything else we'll see later, but at least these three we're going to have to register as we go along, right? They've also given you mnemonic. Use it as you please, okay? Now, classification criteria of PN, usually you need 3 or more out of these 10 to get the diagnosis, right? One of the major ones is, you see, you're not seeing any pulmonary involvement, okay? Because neurons are involved, you see mononeuropathy, in one set of nerves, or polyneuropathy. Testicular pain, right? Because gonadal arteries may be involved, within the aorta. Myalgias, weight loss, all these, livedo reticularis, diastolic blood pressure starting to increase, B1 and creatinine, which means renal involvement is getting worse, maybe Hep B positivity, right? All of these we sort of understand and we get, right? So we just need those 3 at least to, make that diagnosis, okay? And as you see here, we've mostly discussed all of this, so PN is understood. Now, general workup and how you must approach the patient. Okay, with most of these vasculitis, the workup sort of remains the same, because I need to do a full scale workup in order to get the differential ruled out. Okay, so you're gonna start with CBC. The blood work starts with CBC, right? I want ESR or CRP right away, right? So I get the inflammatory markers in. I need to get the renal involvement right away. I need to get the liver involvement right away, right? So all of these are renal involvement, liver enzymes with ALT, AST, maybe they give you direct, indirect bilirubin, we don't know, okay? Then you may see P-ANCA, C-ANCA being involved in most of these cases, right? And in most of these cases, you will see Hep B and C serology, right? The patient might not know that they were exposed to blood products or, dirty needles or, you know, I don't know, like blades or something like that, right? So we need to make sure that we are doing our due diligence to get these serologies, because this makes it easy, and you'll see further, because a lot of Hep C and a lot of Hep B have immune complex vasculitis, and it'll make it easier for us to get to that differential. Okay, because we're talking about blood vessels, you have to do some sort of CT or MRI angiography. Okay, it will help me visualize if there's bleeding or if there's any sort of nodular presentation of the renal artery or any other artery. Okay, and if it's really, really, and I'm not able to get the diagnosis out of all this, maybe biopsy of the affected organ, skin, nerve, vascular tissue, right? Usually vascular tissue is not recommended because of some sort of aneurysm or rupture. But we understand that things like skin biopsy, with the capillaries involved, you will see something. Okay. Now, the thing with this is, of course, you're going to use glucocorticoids, but the discussion is, because it's, a very, very long-term inflammation, you need to make sure that, you're not just making them steroid dependent, right? And then you cause the problems of steroid dependency. Okay, so you start with PN with no major manifestation, glucocorticoid, and azathioprine. Okay, if you see there's organ manifestations, you're going to start to add cyclophosphamide into it, and that's the only thing that we have to remember, right? If these two don't work, then you can, pick and choose whatever hits, right? Methotrexate, leflunomide, but these two are the main go-to now. Okay, Hep B is associated, well, you're going to have to do prednisone, maybe even methylprednisone, but then you have to use plasma exchange and antiviral to make sure Hep B is sort of cleared and you have a less amount of viral load. Okay, so that is the true treatment for PN. Okay, next comes Kawasaki disease, right? Kawasaki disease. Now look at the other name for this. The other name is mucocutaneous lymph node syndrome, right? A lot of those symptoms are already listed. Okay, Kawasaki disease is a pediatric diagnosis, so we have to know that. Okay, now the best way to remember all the involvements is by the mnemonic cream. Okay, usually if you get 4 out of these 5, you have the diagnosis. Okay, so you start with C, conjunctivitis, right? Because the child is going to present with the bulbar congestion, meaning red eyes, right? And usually it's non-purulent, and it's usually bilateral, which means it's not a pink eye, it's not a bacterial crusting, anything like that, right? So it's a dry, normal looking but red eye. Okay, next comes R, which is rashes. Rashes in the perianal region, periungual region, right? And then desquamation. So the rash is peeling, right? Now, the important keyword that they're not saying, and it applies to a different diagnosis, is sandpaper, right? This is something called, you will see that in scarlet fever, but they don't use that word here, right? And the location also matters, right? Perianal, right? And around that anal region, you're seeing desquamative, lesions. Okay, edema, E for edema. So, usually with the hands, like peripheral edema with the hands and the legs in a child, usually you're not supposed to see that, right? So a child coming to you with peripheral edema, that is indicative of Kawasaki. Next comes lymphadenopathy. Lymphadenopathy has to be remembered because it's unilateral, okay? It's not bilateral, unilateral, and you may see it in the cervical region, okay? Cervical region, unilateral lymphadenopathy. Then you see mucosal involvement in the strawberry tongue, which is, the differential for other, bacterial-based, diagnoses, right? Now, complication, because you see, this is classified as the, the number one mortality reason for, in kids with vasculitis, right? So why is that, why does it have the number one position? Because it causes coronary artery aneurysms. Okay, how do you get those? How do you figure out that the person has it? As soon as you see these criteria, you have to get them into echocardiography. Okay, I need to visualize the heart. And even, as I get prepared for the test itself, I need to start them right now on aspirin. One of the few places where you see aspirin being used is this case right here, right? Otherwise, aspirin, Ray syndrome, and all that, right? All the sequelae for that. But right now, here, you need aspirin, okay? If the aspirin is not working, you're going to have to use IVIG, right? But usually, both the combination takes care of the Kawasaki disease, right? Um, in Now the pathophysiology is expanded, and you may see some sort of antibodies that are causing this type of inflammation in these different systemic involvements. But usually, you know they're not giving you any sort of, in the exam, the questions, they're not giving you any sort of antibodies for the diagnosis for Kawasaki yet. Okay. You may see platelets being increased, and that's just a part of how the bone marrow reacts to the inflammation. But apart from that, you're not seeing much. Okay, so that is Kawasaki. And just to review some points here, let's just see. So American Heart Association, 45-year-old child, fever lasts 5 days. This is an important point. Okay, fever persisting for greater than 5 days, right? And then you're showing up with the cream symptoms of Kawasaki disease. It's definitely Kawasaki. Okay, you see, one of the criterias for diagnosis is fever greater than or equal to 5 days. Okay, now you can give all these different paracetamol, or maybe some other antibiotic, right, for a routine bacterial infection, but the fever still persists. Okay, along with these different skin involvement and mucosal involvement symptoms, then you've landed in the diagnosis of Kawasaki disease. Okay. Let's see if there's anything else. Nothing. Now, you may see that the child with untreated Kawasaki disease, now at the second or the third week of the disease, is showing up with chest pain. Okay, showing up with syncope, right? You put an ECG monitor, you're seeing ST elevations on a child and T wave inversions on a child. Okay, it's not supposed to happen, right? The diagnosis should have been made earlier and should have been caught earlier. Okay, so coronary artery vasculitis leading to MI, right? Now, what are you going to do for these guys? So the treatment is just as important at this point as it was earlier, right? Now, but the thing that are, first of all, you cannot do a PCI, right? You cannot do a percutaneous coronary intervention in children, because first of all, you don't really have a thrombus. Okay. Opening, forcefully opening that vessel is not going to help. What seems to be helping is that thrombolysis can be done. Okay, so because you have a coronary artery vasculitis, the vasculitis is causing lumen narrowing. You may see platelets and clots developing in those regions. If you perform thrombolysis, which means give them heparin and things like that, you may see that the blood flow comes back to normal, right? Problem is, because you're giving these thrombolytics, you're going to give, you might give them brain hemorrhage at that point, right? You may have hemorrhagic stroke on your hands. But at least for the time being, the coronary system, right, the heart is still receiving some amount of blood, right? So we're making sure like all those clogged pipes are still, open, right? So that's the basis of treatment. PCI is usually, it's too invasive and it's not suitable for a child. The vessel walls are too narrow, and also, forcefully opening the vessels is not going to help. Okay. And then treatment of the vasculitis as well, IVIG, I have to throw that in there. Okay, so let's see, ECG findings of myocardial infarction in neonates. So they've given you a couple more. Well, this is not too important for us for now. You can take a look at it and read it. All right, next comes Berger's disease. Okay, this is Berger with a U. Very important, right? There is a Berger with no U, right? And it's usually seen as a nephropathy, but this is called thromboangiitis obliterans, right? Obliterans meaning complete obliteration of the lumen. There's no flow at all, okay? Usually this is happening for any sort of type of smoking. May it be tobacco, may it be vapes, anything, okay? Usually what ends up happening is because you're forming large amounts of clots, that's why the thrombo, right? Thrombo, and then the angiitis, which means the inflammation of the capillaries themselves, okay? Because, now you're involving the medium vessels, you're going to see a lot more peripheral vessels involved in this cases, okay? So leg pain, hand involvement, right? So if a person has any sort of injury, right? Let's say a laceration to the finger or the leg, the healing will be delayed as well. So delayed healing is also a part of this whole sequelae because, the nothing is reaching that place, right? Maybe by collateral circulation, you might eventually get some, flow into there, but into the peripherals, right? Into the fingertips or the toe tips. But usually you're not getting anything in there. So healing will be delayed, right? Usually the lymphatics are never affected, and that's a good thing, right? At least the lymphatics are flowing, but again, you can't get your RBCs and WBCs and any sort of nutrients in there, okay? So that is Berger's disease, and there's a lot more to be said for example, Raynaud's phenomena, right? Raynaud's phenomena leading to that spasmodic constriction of the blood vessels under different temperatures. They may be auto amputation, right? Because the entire, fingers are so deprived, they undergo, just amputation, right? You might even see the superficial nodular phlebitis. Why? Because, the veins that were involved because of these, because of the Berger's disease, now you're going to see the inflammation of that nerve because now you can palpate it, right? So palpation of these veins in the legs, right, in a smoker especially, is related to Berger's disease. Okay, so that is Berger's. Now, next we go into small vessel vasculitis, right? Small vessel vasculitis is divided into two categories. We saw it earlier: ANCA associated and complex associated, right? So we have to understand what is ANCA, right? ANCA stands for anti-neutrophilic cytoplasmic antibody, okay? Anti-neutrophilic cytoplasmic antibody, right? There's a C ANCA, which is cytoplasmic ANCA, and there is a P ANCA, which is perinuclear ANCA, right? Now, the markers that, they are, attaching to, right? Those have to be understood as well. So C attaches to PR3, and P attaches to MPO, myeloperoxidase, okay? C ANCA is usually triggered by some sort of infection. So the body starts to make these antibodies against the PR3 antigen during some or after some infection, okay? P ANCA is usually seen with the ingestion of propyl thiouracil, okay? So a person with, let's say, hyperthyroidism, right? How are you going to prevent that, right? You're going to use PTU. So if the person is then presenting with some sort of vasculitis, you know which direction they want you to go to. Okay, so P ANCA versus C ANCA, the major differences are given to you. Okay, now tomorrow they can start to give you these different P ANCA and C ANCA visualizations. I want you to take a closer look at this. When you look at P ANCA, you see perinuclear, which means the highlights, and I'm going to try to zoom in as much as I can, the highlights is around the nucleus. The halo, the green neon sign, is around the nucleus, and the nucleus itself is dark in color. Okay, so perinuclear, right, ANCA. Whereas the cytoplasmic ANCA, right, and I want you to look at the difference here. The entire cytoplasm is involved. Here, not the entire cytoplasm, right? Here, the entire cytoplasm is involved. So that's why this is a C ANCA and this is a P ANCA. Okay? So we understand the histological difference between C. ANCA and P. ANCA. Okay. Now, where do you see the C. ANCA versus P. ANCA involvement? Okay. First of all, Wegener's granulomatosis, or GPA, granulomatosis with polyangiitis, right? That one has more C. ANCA than compared to P. ANCA. Okay, so they're essentially classified as a C. ANCA based vasculitis. Okay, so an example of C. ANCA based vasculitis is Wegener's, right, or granulomatosis with polyangiitis. Okay, everything else is a P. ANCA derived inflammation. Okay, so microscopic, Churg-Strauss, ulcerative, PSC, all of these are P. ANCA derived. They are causing, the antibodies are against the MPO. Okay, so that's the easiest way to remember these. Okay, now you may see that IBD, right, inflammatory bowel disease or rheumatoid, you may see involvement of both of the ANCAs, right? But as a general rule, P. ANCA is involved in almost everything, and sometimes C. ANCA, dominates in certain scenarios. That's how you remember them. Okay. Then we go into granulomatosis with polyangiitis. Okay, GPA. I will refer to this as GPA from here. Okay. Now, GPA has, you may see two triads. Okay. First of all, the triad one that they want you to focus on is kidney involvement, blood vessel involvement, and lung involvement. Okay, so kidney, blood vessels, and lung. Okay, then comes the triad two, which is ENT related. Okay, so otitis media, nasal septal perforation, and strawberry gums. So you see most of the involvement, right? It's limited in the lung sense, but it's more upper respiratory than anything, right? More of the nose and the mouth. Okay, and as you see here, strawberry gums. Okay, so if they're giving you any of these upper respiratory type of symptoms, then you are ready with the GPA diagnosis. Okay, so just to review, granulomatosis with polyangiitis, right? So here is the classification criteria: nasal involvement, so most of the upper respiratory symptoms, right? Any sort of congestion, epistaxis, blockage of the nasal, right? Or the cartilage, for example, ear nose cartilage, maybe, the endobronchial cartilage, the nose cartilage causing, degeneration and producing the saddle nose, right? So the cartilage, because of gravity, the cartilage is basically having this like landslide moment, right? And it forms the saddle, called these saddle nose deformity. Okay, I want you to look at it. It looks kind of like a elf, right? But even that's considered here, right? Hearing loss, again, ENT involvement. So that's the ENT triad. Okay. Now, as it comes to lab and imaging, we know they give a higher weight for lab and imaging, right? So C. ANCA, PR3, we understand that. Okay. Mostly it's C. ANCA, right? P. ANCA is usually, negative point, right? So if you see a P. ANCA positive GPA, they might not actually, consider it, right? As we go down, pulmonary involvement is seen, pulmonary cavitation, mass, maybe nodules. And as you go further down, granuloma, right? It's granulomatosis, right? So granulomas are going to be seen, right? And just as a review of our immunology, granulomas are formed by Th1 cells, right? Th1 cells. So Th1 cells are the things that are, more or less causing that type 4 hypersensitivity that you are seeing in this case. Okay. As we go into the next one, you can finish reading all the remaining ones. When we see the next the next diagnosis, which is eosinophilic granulomatosis with polyangiitis, eosinophilic, right? That means it's a Th2 cell involvement, right? And just make a note of it. When we get there, we get there. But that will be a Th2 cell involvement, right? And Th2 cells are responsible for secreting things like IL-4, 5, and 6. And those are the markers that produce eosinophils. Okay, so those And you see blood eosinophil count, right? -4, because they don't want you to diagnose this as eGPA, right? They want you to diagnose this as GPA. Investigation. We've understood most of this, so we're good. Urinalysis again, you may see, because right now these lead to a sort of a nephritic syndrome in the patients. Okay, when we cover nephritic syndrome, all this data will transfer over, right? But because of the venal artery and small vessels of the renal artery are now involved, right? Capillaries are now involved. Now you're going to see a nephritic type of syndrome becoming, prevalent. Okay, so proteinuria, hematuria, RBC cas, very important. Okay, you're gonna have to do a chest X-ray to see, or a CT, and look at all these different pulmonary findings, right? Confirm by a biopsy with skin or renal or lung, right? Least invasive to more invasive. Okay, and monitoring with CRP, with your therapy. Okay, now we've gone through PN, we've gone through GPA. You can compare and contrast both of them, and they're given here. Okay, PN also shows up with some aspects of PNCA. Okay, so again, very, very important. PNCA can be seen with PN. Okay, and because we know PNCA is mostly MPO derived, so that's how they've compared it here. Okay, just some salient points. Let's just quickly review all of these. So hematuria and hemoptysis are also observed in Goodpasture syndrome, right? Usually there you have GBM damage, right? So they might, it starts to sound similar, because even in these cases you may see hematuria and hemoptysis, and because of the lung involvement. Okay, but you have to consider the whole picture, right? They will have to give you the upper respiratory symptoms, not just hemoptysis. You understand, right? So that's why these diagnoses can be confusing, because they both of them lead to nephritis, and they both lead to something called RPGN, and we'll see this when we go into nephritic syndrome. So both Goodpastures and GPA are classified into nephritic, whereas PAN is not actually causing any sort of glomerulonephritis. Okay, and nor does it have any hemoptysis, right? So we need to distinguish between a couple of these, right? Cyclophosphamide causes hemorrhagic cystitis. That's an adverse effect, very high yield adverse effect, right? Imagine this. I give cyclophosphamide as a treatment for GPA, okay? Tomorrow, I see that the patient is complaining of blood in the urine, right? Well, it could be that it's hematuria, or it could be that the cyclophosphamide also has caused inflammation of the bladder. Okay, what do I need to do? I need to check via cystoscopy. Okay, so hematuria must involve cystoscopy as a part of diagnosis, right? Workup. So always make sure you're doing that, and then you may see the inflammation on the cystoscopy. You may even do a biopsy or whatever to make sure to rule out something else. Okay, so that's why we're limiting ourselves and making sure that double checking that it's just either it's the hematuria or it's the cyclophosphamide, right? Because this can turn into bladder cancer too. Okay, in PN you're going to see all these. They've just reiterated it: combination of gangrene, and yeah, condition in which PNCA is strongly positive. So we'll go over the other ones, but what I want you to put into your brain are these conditions here. Okay, as a good exercise, I would say type C-ANCA in the first aid book. Go through all the pages where they say C-ANCA, type in P-ANCA, go through all those pages too. Okay, so that's a good sort of exercise to do. Right now, let's wrap up the sort of therapy for GPA. Okay, as we saw, glucocorticoids are the first thing. You can combine, or you should combine them with cyclophosphamide or rituximab. Okay, if none of these work and you're seeing severe organ involvement, then you do plasma exchange. Okay, if it's all working, then the maintenance, because you have high amounts of corticosteroids, right? The maintenance can be switched with azathioprine or MTX instead of the corticosteroids. Okay, usually azathioprine is called the I'm forgetting the actual term for it, but it's the glucocorticoid sparing agent, right? It's the first line for the sparing of these corticosteroids. Okay, so azathioprine, methotrexate, or mycophenolate are what are used for maintenance, for long-term maintenance. Okay, for non-organ threatening disease, prednisone plus or minus MTX, and usually for prophylaxis, because you're giving them a lot of corticosteroids, and you're kind of making them immune deficient, you might have to give them some prophylaxis against pneumocystis via TMP-SMX. Okay, so all of this is mentioned here and we're good. Next, moving forward, microscopic polyangiitis. Okay, the best part about this is if you have learned pan properly, all of this is just an opposite of polyarthritis nodosa. There, in polyarthritis nodosa, you have medium vessel vasculitis. Here you have small. There you have association with HB antigen, right? Hepatitis B. Here you do not. There you have sparing of the pulmonary artery. Here, pulmonary artery is affected. There you don't have glomerulonephritis. Here you have glomerulonephritis. Okay? There, the lesions weren't at the same stages, right? They're also Pienka associated. Here, all lesions are at the same stage, right? There, you also had some granulomas that were taking place. Here, you have no granulomas, okay? The only thing that what this is also known as is called leukocytoclastic, right? So white blood cells are breaking the vascular system, and then you get the presentation, okay? So all these involvements, right? Lung, kidney, skin can be involved, right? With the glomerulonephritis and palpable purpura. Okay, so microscopic polyangiitis. And then you see Pienka is also involved there and over here. So this is the only common, benchmark between the two, the order of the Pienka, right? And just to come back to this place, right? So you see Pienka is also mentioned here. Okay. Next comes eosinophilic granulomatosis with polyangiitis. Okay, it's in the name. It's Th2 derived granulomatosis, but with eosinophilia. Now, because you have the eosinophilia, then you see that there's lower respiratory symptoms more prevalent with anything else, right? And you see asthma being the major sort of thing that is presenting. Okay, so more or less the entire function is the same, right? Here you will end up seeing, cardiac death is the most common way for them to go out, but more or less it's more relatively the same. Okay, so lower respiratory tract plus or minus peripheral neuropathy, you're going with EGPA. Okay, next comes, so all we discussed so far were ANCA associated, small vessel vasculitis. Here comes complex associated small vessel vasculitis. Here, now you transition into hypersensitivity type 3. There, it's usually hypersensitivity type 4. It could be type 2, right? But here, it's usually hypersensitivity type 3, right? First and the foremost is the one that's associated with SLE called hypocomplementemic urticarial vasculitis, right? It's a different diagnosis in itself, okay? It leads to skin involvement, joint involvement, and other, ocular plus stomach pain and lungs involvement, right? The main thing is C1q, right? Because all these complements are lost, right? And there's massive amounts of inflammation going on, you see the complements are lost, and they're lost against these antibodies. So antibodies are, eliminating the complements. Okay. So, a lot of usually skin plus, couple of organ involvements right? So stomach, lung, those are the major ones. Okay. Next comes cryoglobulinemic vasculitis. Okay. Now these ones, the cryoglobulin, so it's kind of in the name. The thing is, these are triggered by low temperature. Okay. Now, usually what they sort of present with is usually they have IgM based triggering, right? So this mixed cryoglobulinemia is this exact thing right here. Okay. So usually it's IgM based. It can be IgG based, right? And they precipitate because of reduced temperatures. Now, they usually, what they present with is, again, the purpura, which means, the capillaries of the skin are affected. The capillaries of the joints are affected. Neuropathy, which means capillaries of the neurons and capillaries of the renal system, right? So those are the four things that you're seeing very, very frequently, okay? Now, renal disease is seen, and in 40% of the patients, you may have some sort of nephritic, outcome. Okay, because you have high type 3 hypersensitivity, we know immune complexes can trigger complement cascades. Okay, so complement cascades, and usually you have decreased C4 that are because C4 is usually being consumed, right? And usually I think C4 is some like a classical complement pathway, right? So you may see the involvement of complements, right? Treatment, because these are very, very closely related to HCV, you have to make sure you're trying to eliminate the HCV as well, right? So plasmapheresis, steroid cyclophosphamide for the HCV. You may see that they're coinciding because of the IgM type. You may see multiple myeloma also being mentioned there, but usually you may have to add some sort of antiviral as well into this type of presentation. Okay. Next comes cutaneous small vessel vasculitis. So it's just on the surface, right? Only skin involvement, right? And it's usually this, similar to microscopic polyangiitis, right? So you see this leukocytoclastic vasculitis. Okay. Why is it happening? Because of some sort of drug introduction. Okay. So usually some antibiotics, phentoin, allopurinol, or maybe HCV and HIV infection, right? But they're just going to say that there's skin involvement and that's about it. Okay. Next comes HSP, okay? Hinlock-Schillen purpura, right? Now, this is an IgA vasculitis, right? So what you end up doing in this case is you have IgGs against an IgA, right? And it should be mentioned somewhere. I guess it's not. That's okay, right? So what ends up happening is you have vasculitis secondary to IgA immune complex deposition, right? So you are depositing all the IgAs and it's all being consumed, okay? So what you end up seeing is this mnemonic, most commonly called purpura, okay? So the organs affected, first of all, palpable purpura, usually on the extensive surfaces of the lower limbs, joint involvement, as with most of them, right? But then you see the internal visceral organ involvement, abdominal pain because of some sort of GI, and hematuria, okay? And again, a lot of it is just related to IgA vasculitis, okay? Now, if they say most common vasculitis, you have to remember HSP. If they say most common vasculitis leading to death, as we discussed, is Kawasaki. Okay. Now, a couple of important information that you may come across. Okay. If they say non-palpable purpura, right? Non-palpable. Why is it non-palpable? What is the difference between palpable and non-palpable? Palpable means that there's inflammation. Okay, it's raising outside the skin border, right? That is Hinlock-Schillen purpura. Whereas non-palpable just means that there's subepidermal bleeding, right? So that's immune thrombocytic purpura, thrombocytopenic purpura. Okay, pinch purpura. Amyloidosis, we understand because of fragility of blood capillaries. So you may see that as a factor. Okay. Now, let's just quickly see if there's any other information that we are missing out. Blood vessels of the skin, extensor purpura, may be misidentified as a viral, pediatric rash, right? So chickenpox or measles, usually they present with rash on extremities. They have, maculopapular vesicular rash. So they have every different type of, they have a macula, they have a papilla, they have vesicles. They have all different types of characteristics when it comes to chickenpox, right? So always remember, even though it's palpable purpura, there's no macular or vesicular in HSP, okay? Measles. Rash starts from the back of the ear and it's relatively small and it goes downwards, right? So even this is considered maculopapular, but the spread of the rash is different, okay? Vasculitis related to GI vessels, and you see the GI symptoms as well as the joints in the synovium. I think we got this, we're good. Elevated IgA levels, low C3 levels, maybe even C4 levels, and then usually it's just steroids, right? Yeah, so that's about it. So let me see. Raised palpable purpura, bowel angina, diagnostic biopsy. You can perform a diagnostic biopsy of the skin, usually skin, and see if there's any what the blood vessels actually look like. All right, now this is an important sort of set of information. We need to make sure Kawasaki disease came earlier and it went away, but we have to make sure we can differentiate with all the points between scarlet fever and Kawasaki disease. Okay, so Kawasaki disease and scarlet fever presents with in children, right? Scarlet fever is a problem with strep pyogenes, right? Strep pyogenes with fever that lasts for less than 4 days. What did I say with Kawasaki? Greater than 5 days. Okay, so that's the first point of differentiation. Okay, it's self-limiting and it's usually for less than 4 days. Okay, this will respond to your paracetamol, right? Plus any sort of maybe therapy like antibiotic therapy, right? This won't. Okay, where's the rash and how is it? The rash is all over the body. It's sandpaper, so it's gritty in texture, right? What happens when you physically examine the patient's body? You see on the dependent surfaces like axilla and inguinal region, etc. You see there's multiple lines called pastia lines, right? And you may see some mild desquamation, but it's only on those highly foldable, those creases. Okay, so those are called pastia lines, right? Unilateral lymphadenopathy here, bilateral cervical lymphadenopathy over here. Okay, management for scarlet fever usually is some sort of penicillin derived thing because it's all gram-positive bacteria, so we have to monitor for that. Okay, so just a quick summary. You see they've given you all the strawberry presentations that you may come across, right? Strawberry gallbladder, cholesterolysis, right? Cholesterol stones. Strawberry cervix, trichomonas. Strawberry gingiva. We saw this, remember? The gums being inflamed, right? So granulomatous with polyangiitis. Strawberry nose, rhinosporidiosis, right? So it's like a fungal inflammation. Strawberry tongue, right? Kawasaki disease or scarlet fever. So now we know the differentials for all these. Quick sort of differentiation between GPA, MPA, and EGPA. All of these are given to you, right? And we've sort of reviewed most of them, right? Last one, because it goes through the entire large, medium, small, it can present with a variety of things, right? Large vessel, you see pulmonary artery, even though it's rare. CNS involvement is heavy, right? Why does Behçet's disease usually take place? It's usually because of some sort of genetic involvement, right? So a person coming to you with B51 association, okay? Then they come to you with venous thrombosis, right? Dural sinus thrombosis. Usually, if you're expecting a stroke, you're expecting it in the arterioles. Here, you're seeing it in the veins too, okay? Then you see small vessel, you see mucosal involvement, genital ulcers. Very important. You see, whenever you see genital ulcers, you're like, oh, it's an STD, right? Or you see ulcers with uveitis, you may think of some sort of viral, problem, right? But in this case, you're seeing multiple things, and they've given you the differential here, right? So encephalopathy with genital ulcers, usually it's a herpes thing, herpes simplex virus, right? But in there, you may not see any uveitis or any ulcer, right? But here you're seeing that the progression of the Behçet's disease is involving the eye, it's involving mucous membranes, and it's involving the CNS, and that's how it sort of presents. Okay, it's also called oral oculogenital, right? Oral oculogenital vasculitis. Okay, and you can see the pictures, and you see different, women with vulvar ulcers, with scrotal ulcers, hypopyon with in the eye, and then the test that they like to do with Behçet's disease is the pathergy test. Okay, pathergy test is basically a type 4 hypersensitivity reaction where they take this needle and prick it, and usually there's nothing injected, but in the patients with Behçet's disease, you see that there's a pustule formation within 2 to 3 days, right? Usually there's no, in the normal person, you're not going to see anything, right? But here, because of the involvement of the small vessels, right, you may see that there's a small pustule rounding that punctured region. Okay, so it's a nice and enclosed space now, right? So that is a pathergy test, right? Just a simple poke can elicit this pustule formation. Okay, and I think we've seen most of these. You see small vessel vasculitis involving the brain blood vessels. CNS manifestation, very, very peculiar, right? You may see abnormal behavior, venous thrombosis, and encephalopathy, right? So this is termed as neuro-Behçet's disease, and it's important to remember that if they ever say CNS manifestation with skin involvement or eye involvement, always think of Behçet's versus herpes. Okay, herpes is a very common question by itself, right? With the temporal artery involvement, seizures, they say smell discrepancies, and they give you the temporal lobe and the CT scans being involved. So a lot of that is asked, but always have this as a differential. Okay, treatment, easy, topical steroids, azathioprine, methylprednisone. Usually the 3 that you always see. Okay, the workup we've discussed in the different vasculitis, that's also applying here too. Okay, lastly, I've given you these miscellaneous nephritis. Please go over them, right? All the different infectious agents that are leading to some sort of nephritis. Okay, infective endocarditis, Hep B, Hep C, syphilis. We'll cover a lot of them in nephritic and nephrotic syndromes, but for us for now, our information is limited to this thing. Okay.